Hello, my name is Dr. Oscar Hernandez alongside my colleagues Marwa Hussain, MS4, and Doctors Gaisinskaya, Shah, and Zahra. And today we would like to present a case of duodenal fibrosis mimicking neoplastic obstructive hepatopathy in the setting of Lynch syndrome. For some background, inflammation in response to injury can result to connective tissue deposition with resultant fibrosis. Up to 10% of patients exposed to abdominal radiation therapy can experience gastrointestinal or GI fibrosis. Complications of GI fibrosis include dysmotility, impaired secretions, and possible obstructions. In addition, Lynch syndrome or hereditary non-polyposis colorectal carcinoma is an autosomal dominant disease leading to generation of polyps with malignant potential. Lynch syndrome polyps are typically found in the colon and rarely have extracolonic manifestations in the small bowel. Most notably, most extracolonic manifestations of Lynch syndrome occur in women and are typically found in the endometrium or ovarian areas. For our case, we had a 61-year-old male with a past medical history of Lynch syndrome who presented with a 6-month history of progressive weakness, fatigue, weight loss, and chronic non-bloody diarrhea. Of note, his previous medical history also included stage 4 colorectal and small bowel adenocarcinoma, which required duodenal resection and subsequent duodenojejunectomy 5 years prior, followed by abdominal radiation. The patient described his diarrhea as pale and watery stools with about 2 to 3 episodes per day. He denied abdominal pain, fever, or recent travel. After an initial physical examination was completed, lab work was conducted, which showed evidence of a cholestatic pattern as seen here in Table 1. Of note, alkaline phosphatase, gamma-glutamyl-transferase, lipase are all elevated, in addition to a lack of fecal elastase, which demonstrated an increased suspicion for us that a pancreatic obstruction may be occurring at this time. Therefore, a subsequent CT of the abdomen and pelvis was conducted, which showed significant intrahepatic, bile, and pancreatic duct dilations. Due to our findings, our suspicions were very high for a recurrence of his Lynch syndrome in the area of his duodenum, possibly leading to compressive obstruction. Therefore, an advanced endoscopist was consulted for further evaluation. A subsequent ERCP and EUS had surprising findings. First, there was no evidence of mass compression from a secondary colorectal cancer incident. However, what was noted was advanced duodenal fibrosis originating from the nidus of his original surgery site at the duodenal jejunostomy site. After multiple attempts to pass a stent through the ampulla of Vater failed due to extensive fibrosis, the decision was made to conduct a palliative transgastric drainage. Image 1 shows deployment of our transgastric biliary drain through the gastric wall. Image 2 shows the visible flow of the accumulated bile and pancreatic excretions which have been accumulating in the pancreatic and biliary ducts. Postoperatively, the patient's appetite, fatigue, and lab values all improved. Fecal elastase was repeated and noted to be found in improving quantities in his stool, thus demonstrating improved flow of pancreatic exocrine enzymes into the stool. He was subsequently discharged on admission day 4 to follow up with his primary care physician and gastroenterologist outpatient. Small bowel adenocarcinoma in the setting of Lynch syndrome is a rare and notable finding. Furthermore, duodenal fibrosis is also another rare finding in the setting of recurrent instrumentation and radiation. Adhesions are more often seen in these patients than fibrosis. We believe that his sequelae were secondary to lack of flow of exocrine enzymes via biliary and pancreatic conduits. Early involvement of an advanced endoscopist in this case was vital to treating his suspected obstructions, and transgastric stenting, although not curative, is a palliative measure for these patients. If you would like to read more about our paper, you can use your phone camera to point at this QR code and download a more full version of this paper. Thank you.